Case presentation. A 7-day-old male neonate was brought to the emergency department with a 1-day history of refusal to feed and jaundice. The infant was born at term with an uncomplicated antenatal period and delivery. Initially, the presentation was suspected to be due to late-onset neonatal sepsis. However, the sepsis workup, including blood culture, was negative. The random blood sugar was 52 milligrams per deciliter. Treatment was initiated with intravenous antibiotics, intravenous fluids, and phototherapy. Cerebrospinal fluid analysis was normal. The neonate's condition improved and feeds were initiated. The child experienced 10 to 12 episodes of vomiting after feeding, appeared irritable, and had multiple generalized tonic-clonic seizures. Despite anticonvulsant therapy, the seizures persisted, necessitating the addition of a second anticonvulsant. Renal function tests, liver function tests, urine routine examination, blood culture, and CSF analysis were normal. Now, what other tests would you order? Yes. The ABG showed severe metabolic acidosis with an anion gap of 36 millimoles per liter, with negative urine ketone bodies. Serum ammonia, 388 micromoles per liter, and serum lactate, 46 milligrams per deciliter, levels were elevated. Now, take a break and review the case all over again. What diagnosis do you have in mind? Here are the clinical presentations, hospital course, initial management, and laboratory investigations of the child. An initial diagnosis of organic acidemia was made. Tandem mass spectrometry confirmed the diagnosis of propionic acidemia, which is one of the inborn errors of metabolism. Inborn errors of metabolism. Inborn errors of metabolism represent a group of rare but potentially life-threatening disorders that pose significant diagnostic and management challenges. With an incidence of approximately 1 in 4,000 live births, these conditions cannot be overlooked in the clinical setting. Despite their rarity, a thorough understanding of inborn errors of metabolism is crucial for healthcare professionals, as prompt recognition and appropriate management can significantly improve patient outcomes. Pathophysiology. Inborn errors of metabolism stem from genetic defects in the intricate metabolic pathways responsible for converting proteins into energy. These defects lead to the accumulation of toxic metabolites, which can wreak havoc on various organ systems. The precise metabolic pathway affected determines the clinical presentation and severity of the disorder. Typically, the defects involve deficiencies or abnormalities in enzymes that facilitate the breakdown and utilization of essential nutrients, leading to the accumulation of toxic byproducts. Clinical presentation. The clinical manifestations of inborn errors of metabolism can be diverse and nonspecific, presenting a diagnostic challenge. Neonates with inborn errors of metabolism often appear well at birth but decompensate rapidly, exhibiting a wide range of symptoms. Neurological symptoms, such as lethargy, altered mental status, and seizures, are common. Gastrointestinal disturbances, including vomiting, poor feeding, and abdominal distension, may also be present. In some cases, the clinical picture may resemble sepsis, with multi-system involvement and organ dysfunction. Diagnostic evaluation. A markedly elevated serum ammonia level, typically exceeding 180 micromoles per liter, is a key diagnostic finding that should prompt the consideration of an inborn error of metabolism. However, the diagnostic evaluation may require a comprehensive approach, including biochemical testing, enzyme assays, and genetic analyses. Hypoglycemia may be present, though this is usually a later finding. Prompt recognition and appropriate testing are crucial, as delays can have devastating consequences. Management principles. The management of inborn errors of metabolism involves two critical components: stopping protein intake and providing an alternative energy source. Neonates are made NPO, effectively halting the intake of proteins that contribute to the accumulation of toxic metabolites. Simultaneously, intravenous glucose is administered as an alternative energy source to meet the body's metabolic demands. Additional supportive measures, such as fluid resuscitation, electrolyte correction, and treatment of specific metabolic derangements, may be necessary. Complications and prognosis. Despite prompt treatment, inborn errors of metabolism are associated with significant morbidity and mortality rates, as high as 50% in some cases. Intractable seizures, which can be a manifestation of pyridoxine, vitamin B6, deficiency, represent a potentially life-threatening complication. Neonates with intractable seizures unresponsive to anti-epileptic drugs should receive an empiric trial of pyridoxine at 1 mg intramuscularly. Other complications may include neurological impairment, developmental delays, and organ dysfunction, depending on the specific inborn error of metabolism and the severity of the metabolic derangement. Take-home message. Inborn errors of metabolism are rare but potentially devastating conditions that require a high index of suspicion and prompt action from healthcare professionals. Markedly elevated serum ammonia level greater than 180 micromoles per liter is a key finding. Early recognition, accurate diagnosis, and timely management are crucial in improving outcomes for these patients. Healthcare professionals must remain vigilant for the clinical manifestations of inborn errors of metabolism and be prepared to initiate appropriate treatment protocols promptly. A multidisciplinary approach involving specialists in metabolic disorders, genetics, and neonatology is often necessary to ensure optimal patient care and management. The major categories of inborn errors of metabolism include disorders of amino acid metabolism, such as phenylketonuria and homocystinuria, disorders of carbohydrate metabolism, such as galactosemia and glycogen storage diseases, disorders of lipid metabolism, such as Gaucher disease and Niemann-Pick disease, disorders of nucleic acid metabolism, such as Lesch-Nyhan syndrome, disorders of porphyrin and heme metabolism, such as acute intermittent porphyria, disorders of mitochondrial function, such as Kern-Sayer syndrome, disorders of peroxisomal function, such as Zellweger syndrome.
Thank you for watching. Please subscribe to our channel by clicking the subscription button. If you have any questions, feel free to leave a comment below in the comments section.